Okay, so I want to start, if everybody could quiet down. It's my pleasure to introduce to you Dr. Tim Padera today, giving our seminar, both for the Cancer Biology Graduate Program and the Cancer Center Seminar Series. Lindsay decided to invite him to come and talk after reading his lab's amazing paper in Science this year. And so a little bit of background. He did his bachelor's in chemical and biomedical engineering at Northwestern University, followed by a PhD at MIT with Rakesh Jain in medical engineering. He then moved on to being a research fellow in the tumor biology program with Rakesh Jain, and is now an associate professor in radiation oncology at Harvard Medical School. So, with Tim's permission, I'm telling you the story of how I know Tim and why I wanted him to come today. 4 years ago, when I first became interested in lymphatics, I was selected to give a talk in the same session as Tim at the Lymphatic Gordon Conference, which was a really new area of research for me. He gave a beautiful presentation showing amazing intravital imaging, which I'm sure you'll see some of today. Then I talked about the mammary gland. Then we went to the bar, and I said, you know your lymph node is right in the middle of the organ that I study, which is the mammary gland? He said, no, there's no mammary gland there. So I called my technician and said, open up a mouse, send me a picture. I showed it to him. He believed me. He said, oh, the fat that we normally have to get rid of. So I just want to acknowledge his sense of humor, because for the rest of the meeting, it was all about how an engineer can't recognize a mammary gland when it's right in front of him. So with that, I will let him tell us about his work and just say that he's been a tremendous mentor for me. So anybody who wants mentoring on lymphatic biology, I encourage you to get in touch. Thank you for coming.
And in my defense, it's only true in half the mice we study. So I think thank you, Tracy, for that introduction, and thank you for the invitation. And Lindsay, thank you for the invitation to participate in this seminar series and to present some of the work for my group. I had a great day yesterday meeting with some of the immunology people, and it's been a great morning, and I'm looking forward to the rest of the visit here in Denver. So my lab has two main focuses, and they're both centered on the lymphatic system. In one area, we actually study the lymphatic vessels themselves and how they grow and mature and function, with a particular emphasis in the role they play in a variety of different disease processes. And the other part of my group, we study lymph node metastasis and thinking about how cancer cells can get to the lymph node, and then how that cancer cell in the lymph node might help drive disease progression. And to do that, as Tracy mentioned, we do a lot of intravital microscopy, where we take a living animal and we'll place it under a microscope. And then using some of our disease models, we can then follow the processes of that disease development longitudinally over time. And then also think about how it might respond to different experimental therapeutics. So that sort of is a big overview of what we do in my group. What I thought I'd do today is I'm just going to spend a few minutes to highlight some of our work studying lymphatic vessels themselves. And then I'll spend most of the time speaking about our work on lymph node metastasis. So first, I have no conflicts of interest to declare. So I'm going to start with this image of the lymphatic system. It's actually one of my favorite images of the lymphatic system. And so these are the dermal lymphatics in the chest. And one of the reasons I like this image is because it highlights that there's different types of lymphatic vessels. You can see these small little root-like structures. These are initial lymphatic vessels. These are the lymphatic, the main job for these is actually absorb interstitial fluid and pull it into the lymphatic system to create lymph. And with that fluid, it's pulling in antigen and antigen-presenting cells. These larger lymphatic vessels are collecting lymphatic vessels. And their main job is transport. They take that newly formed lymph and they return it back through lymph nodes back to the circulation, where it re-enters the blood underneath the clavicles. And we've taken a particular interest in these larger collecting lymphatic vessels because they have some unique biological properties. So when you start to look at these at a microarchitectural level, you can see that these collecting lymphatics have intraluminal valves, similar to what you'd find in veins. And that's really to make sure that the lymph goes in the right direction. So they're check valves, making sure lymph is heading back toward the circulation. The other thing is that they're invested in a specialized muscle cell called the lymphatic muscle cell. And it's really a hybrid cell between a cardiac muscle cell and the vascular smooth muscle cells that you'd see sitting on an artery. And so why do lymphatics need muscle cells? So we can understand it on this artery. The arteries have a high pressure system, so they need structural integrity. And we know that arterioles can constrict and dilate to help shunt blood flow to various places. But lymphatics are a low pressure system. So why do they need this musculature? We can imagine as I'm standing here, I'm creating lymph in my lower legs and feet, and that lymph has to get pumped up against gravity. It has to get pushed through high resistance lymph nodes and eventually repressurized to venous return pressure so it can enter the blood. And unlike the blood vasculature, which has a nice big pump sitting in the middle of the system, the heart pumping the fluid around, lymphatics don't have that. So the vessels themselves have to pump to move the fluid forward. So this pumping, along with these valves, basically helps the fluid get up from the floor up to my clavicles. And so this was an example of our intervallar microscopy. This is the afferent lymphatic to the popliteal lymph node in the mouse. And this is the first demonstration of this contraction in a mouse model. It had been shown in larger animals. And this was a technique developed by Shan Liao when she was a postdoc in my group, and she's now an assistant professor up at the University of Calgary. And the main advantage of this model, because it was in the mouse, now we had a variety of genetic tools and molecular tools to be able to study how this process is controlled at a molecular level. And the reason why, as an engineer, I found this very interesting is because these lymphatics pump sort of on their own, responding to local pressures and tissue microenvironments, but there's no central control. So the lymphatics that are in my legs are behaving differently than when I raise my arm and gravity is helping drain lymph flow. So how is all that controlled? How is all that regulated? And I don't have a lot of time to get into that story, but just to give you a sense of some of the work that we do in both using experimental models and molecular experiments, as well as some mathematical modeling with my collaborator Lance Munn, we've been able to show that two molecules are really critical to this sustained sort of autonomous contraction properties. The first is calcium signaling. They do have properties of cardiac muscle cell that you get these rapid contractions. And similar to cardiac muscle cells, you need basically action potential like calcium signaling. That in conjunction with another molecule, which is nitric oxide. Nitric oxide in the blood vessel world is known as a vasodilator, but it has some unique properties in that it can be produced rapidly in response to flow by endothelial cells, and it also degrades very quickly. So you can actually create gradients both spatially and in time of where nitric oxide is produced. And this has actually been measured in lymphatics. And so this very temporally controlled nitric oxide signaling in conjunction with the calcium allows for these sustained contractions without a sort of central control mechanism. So we study this physiology, but the real reason is so that we can understand the role of lymphatics in a variety of disease processes. And I'm just going to highlight a few. The first is classically lymphedema. Lymphedema is the failure of the lymphatic system to maintain that tissue fluid balance. Worldwide, there's about 100 million cases. The most common cause is a parasitic infection called filariasis. In the US, there's about 3 million lymphedema patients, and the most common cause is actually treatment for cancer, and that's the case of this woman here. She had a left-sided breast cancer, metastasized to the lymph nodes under her arm. Those nodes were surgically removed, she got radiation, and then months to years later, she developed this lymphedema. Now for her, there is no cure for lymphedema. Her treatment is going to be compression wrappings to try and prevent it from getting worse. There's some manual lymphatic drainage. It's like a massage therapy, skin care. But there is no drug for lymphedema. In fact, there's no drug to improve lymphatic function. And that's what motivates us to do all that basic work in trying to understand how this lymphatic system works, is trying to understand the basics so that we can figure out what goes wrong and hopefully provide solutions. Now, one of the other common issues with lymphedema is that you not only have lost your tissue fluid balance, the fluid is sitting there, but also antigen and antigen-presenting cells are no longer able to get to the lymph node. And so patients with lymphedema get very prone to getting soft and, skin and soft tissue infections, SSTIs. So these are bacterial infections. And so lymphedema patients will commonly get these SSTIs, and they'll get them frequently. And so they can be hospitalized for this, and it becomes difficult medical management. But then there's different patients that can develop SSTIs that have no known lymphatic dysfunction, And many of them then develop a pattern of getting recurrent SSTIs. And many of those patients go on to develop long-term lymphedema. So we're seeing this association between these bacterial infections and lymphatic function, or poor lymphatic function. And so we asked the question, what are these bacterial infections doing to our lymphatic function? And so Dennis Jones, who's a current postdoctoral fellow in my group, got his hands on one of the more common bugs in the US causing these SSTIs called Staph aureus. So it's the methicillin-resistant form, so MRSA. And he injected them into our pumping model, lymphatic pumping model. So there's our uninfected animal. And that video isn't playing, but it doesn't really look much different when it does. And you can see that the bacterial infections have basically shut down this pumping function. And so we studied a lot of the different things of what might be causing this, and I will cut to the chase that the critical observation that Dennis made with this was that it wasn't that this lymphatic pumping was shut down only when the bacteria were present. It was basically a permanent depletion of this pumping. And we knew that the bacteria had been removed from the animal by about day 30. We can look for it by PCR, colony formation assays. The bacteria are gone. But as you look over time, so ejection fraction is how we measure the strength of contraction, you see basically a permanent impairment to this lymphatic function. And so Dennis started looking at the structure of the lymphatic vessels themselves. And what he found was that and these are just two ways to look at those lymphatic muscle cells, is that with those bacterial infections, you start to lose the lymphatic muscle cell coverage on these vessels. They're disorganized, and they've lost sort of their normal morphology. And that was true 4 days, 30 days after infection, and he looked out 260 days after infection. You still see this impairment. And then he measured lymph flow out that far, and it was still impaired. So basically, we see with these MRSA infections more or less a permanent damage to the lymphatic vessels. And so how are the bugs doing this? Well, again, I'll sort of abbreviate the story. What he found by using cultures of lymphatic muscle cells and taking conditioned media, that there was toxins produced by the bacteria that were causing this death of the lymphatic muscle cells. And luckily for us, many of these toxins were controlled by a single genetic element in the MRSA genome called the accessory gene regulator. And we have a collaborator at the NIH named Michael Otto that had knockout strains of the MRSA for the AGR. So if we infect then animals with an AGR mutant, we're able to sustain that lymphatic contraction. So what we learned is that the bacteria are producing toxins controlled by this AGR. We don't know which toxin yet, so this is part of the future work. But that these bacteria are shutting down this lymphatic function, and that then maps to the phenotype of patients getting these recurrent infections and developing long-term lymphedema. So obviously the goals are either identify toxins and block them or potentially block the AGR to try and sustain lymphatic contractions through these bacterial infections to hopefully prevent recurrences and prevent lymphedema. So that's hopefully just giving you a flavor of some of the work we do with lymphatic vessels. We're interested not only in bacterial infections, but also the role of how lymphatic function decreases with aging and how that affects immune function, the role of lymphatics in obesity and other disease settings. So, but with that, I think I'm going to transition, because we're in a cancer symposium, to our work studying lymph node metastasis. So this is our organ, and really I view it as an organ that's receiving cancer cells and allows us then to ask a variety of questions as to how the lymph node microenvironment affects the phenotype of the cancer cells, but then also how the cancer cells sitting in this organ that's supposed to generate adaptive immunity can then affect the ability to develop any immune response, including that to the tumor. So when I first got interested in studying the role of the lymphatic system in cancer progression, it really started from observations that had been in the literature for almost 100 years, which was that solid tumors didn't seem to have functional lymphatic vessels. And that was dogma. But there was a paradox, because we knew that cancer was spreading through lymphatics to lymph nodes. And so we used some of our intravital microscopy tools and some functional lymphatic assays to look into solid tumors and actually couldn't find lymphatic function. And at this time, there was now ability to stain for lymphatic endothelial cells. The markers were just being identified, and lymphatic growth factors were being identified. And the most potent ones were vascular endothelial growth factors C and D. So VEGF, C, and D. Part of the VEGF family. VEGF-A, of course, is the potent angiogenic molecule, also the target of like billions and billions of dollars of anti-angiogenic drugs. But people were finding with these lymphatic growth factors that patients with high VEGF-C or VEGF-D in their tumors were more prone to get lymph node metastasis and have worse prognosis. So we thought, well, maybe if we overexpress VEGF-C and try and induce lymphangiogenesis, we can create a functional lymphatic vasculature inside the tumors. So we did those experiments, and when we stained, we could find more lymphatic endothelial cells, but we never found functional vessels. But yet we did get an increase in lymph node metastasis. So where we saw an effect was in all the lymphatics sitting in the margin of the tumors and the peritumor lymphatic vessels. Those became dilated in response to VEGF-C, and that then mapped to the increase in lymph node metastasis. So looking back, thinking that one molecule, one growth factor can induce a functional lymphatic system in the tumor actually probably didn't really make much sense, because this finding that there was no functional lymphatics in tumors was basically universal across many, many tumor types. We know tumors are heterogeneous. We know they have different genetic mutations. So one growth factor doesn't make sense for the lack of lymphatics. And so we started thinking, what are sort of commonalities across all solid tumors? And so if you think about it, it's a bunch of cells that start growing, hyperproliferating, generally in a confined space. And as they do that, they have to kind of create room from themselves. They start pushing on things. And so they actually are generating a force. And we know that clinically they can generate a force because there are syndromes in which that becomes actually a medical emergency. One is superior vena cava syndrome. So this is where a tumor starts growing around the great vessel and literally closing it off. And so this is a gross specimen of it. You can see it on imaging. Similarly, spinal cord compressions, where the tumor will start growing in against the spinal cord, pinching it off. Patients lose neurological functions. You come in and irradiate that lesion, their neurologic function comes back when you relieve that force. So know that the tumors can push. And so we basically asked, can that same compressive force be happening at a microarchitectural level inside the tumor? And when we started looking at the histology of a tumor with these lymphatic endothelial cells stained, we noticed that they never had an open lumen. They actually kind of looked compressed. So we caused tumor cell-specific cell death in a model, and we saw that then these vasculature could open. And so it did seem to be this pushing force. So if that's really true, could we use cell density as a surrogate for the compacting force that these tumor cells are experiencing? And so we did that. We took untreated tumors and just segmented vessels, and whether they had closed lumens or open lumens, both blood and lymphatic and blood, and then measured cell densities around them. And cancers with higher cell density areas were where we found the compressed vessels. So again, suggesting that this really is a compressive force, and when you have less compressive force, the lymphatics are able to maintain their openness. So where does this happen in terms of tumor progression? So looking at a spontaneous model of tumor formation, this is the Paul Ada mice, where you can expose them to UVB and create these lesions up in the skin. You can see, so here's a wild-type animal exposed to UVB where all the lymphatic vessels are open. And then you can create these hyperplastic, dysplastic, very early lesions. And surrounding them, the vessels are all open, but you even start to see compression very early in this dysplastic regions. And then when you get a full-blown tumor, basically all the vessels are compressed. So this is a process that's occurring. As the tumor is growing, that force is increasing, and you start compressing more and more vessels. So that gives us an explanation, a little bit, at least one mechanism for why we don't see functional lymphatic vessels inside the tumors. So that meant we should really be focusing on those peritumor lymphatic vessels. So in order to study those, then we tried to create models where we can image each step in the process of lymphatic metastasis, starting at the primary tumor, looking at the tumor draining lymphatic vasculature, and then down in the lymph node. And again, when we overexpress VEGF-C, we see this hyperplasia of the tumor draining lymphatic vasculature. It led to increased lymph flow, more cancer cells getting to the node. We then asked, well, can we block this process? So the main growth factor receptor for VEGF-C is VEGFR3, using a monoclonal antibody. We can block that hyperplasia of the tumor draining lymphatic vasculature, reduce the cells that get to the lymph node, and basically prevent lymph node metastasis. So that's a nice finding. But when we try to think about how you could translate that finding clinically, it becomes a very challenging point in clinical intervention, because many patients will have developed their tumors for years and have already spread to the lymph nodes by the time they're seen by their physician. So what we really wanted to be able to do is treat a lymph node that was already seeded with cancer cells. And so we did our experiment a little bit differently. We grew our primary tumor, we let it spontaneously metastasize to the lymph node, surgically removed the primary tumor, and then began our treatment. When we did that, we saw no effect. Okay, so that was disappointing. So at this time, we thought, well, let's think about what a cancer cell needs to do when it gets to that lymph node. If it wants to continue to grow and expand, it's going to need it to meet its metabolic needs. So it's going to try and recruit a vascular supply. And so we sort of was thinking of the Folkman hypothesis of angiogenesis here. And so we thought, well, should we add an anti-angiogenic therapy to our anti-lymphatic therapy to try to treat lymph node metastasis? So we got our hands on two small molecule tyrosine kinase inhibitors, cediranib and vendetinib, and they're both from AstraZeneca, and they both have anti-VEGFR3 activity and VEGFR2 activity. VEGFR2 is the main growth factor receptor for VEGF-A, and critical for angiogenesis. And so using these drugs to treat our primary tumors, they both were able to slow the growth of the primary tumor. We looked with histology to show in the primary tumor, staining for blood vessels, that they were both able to reduce blood vessel density. So the drugs were working in our primary tumor. They were inhibiting angiogenesis. What's going on with lymphatic vessels? So here's, again, images from some of our intravital microscopy. Here's our untreated tumor with this hyperplastic tumor-draining lymphatic vasculature. Treating with cediranib was able to inhibit that hyperplasia. Vendetinib really actually didn't have any effect. And those results then corresponded to the number of cancer cells that then found their way down to the tumor-draining lymph node. So green cancer cells, red is highlighting lymph node tissue, and here you can see cediranib is limiting the cancer cells and vendetinib, again, having no effect. So not surprisingly, that then tracked with the number of animals that then went on to develop lymph node metastasis, and cediranib was able to inhibit that. So again, that's a nice story, but not what our real target goal was. What we really wanted to be able to do was to be able to take a lymph node that was already seeded with cancer cells and then treat it. So we did our experiment where we grew our primary tumor untreated, let it spontaneously metastasize to tumor-draining lymph nodes, removed the primary tumor, and then began our treatment. And when we did that, we saw no effect. So this is a very disappointing result. We had two treatments that were active in our primary site. They were slowing tumor growth, they were inhibiting angiogenesis. One of the drugs was able to reduce peritumor lymphatic hyperplasia and prevent cancer cells from getting the node and prevent lymph node metastasis. But once the cancer cells were seeded into the lymph node, we saw no effect. So the question, of course, is why? What was going on? And so as I was doing this work, I was also collaborating with Ben Vakic and Ryan Laning, who's actually now on the faculty here at UC Denver. This is back when he was a graduate student. And what Ben Vakic, who's still at the Mass General, he's an expert in optical coherence tomography. And he was developing tools to be able to image blood vessels without the need for injected contrast. And so these are some of the images of the vasculature, and it's a depth projection, so to orient you, yellow is closest to you, and as you move deeper and deeper into the screen, it turns to oranges and reds and purples. And one of the experiments Ryan and Ben did was to take the exact same cancer cells and grow them in different microenvironments. So they took the breast cancer cells, grew them orthotopically in the mammary fat pad, up in the brain as a metastatic lesion, and in the skin, just because it was convenient for our imaging. And now when you look at these vasculatures, you can see that they're very, very different. Same cancer cells, different microenvironment, you get a phenotypically different vasculature. So what we didn't have here was this block here telling us what the lymph node vasculature looked like. And so in order to do that, we needed to create a model that allowed us then to image into the lymph node. And so that's the lymph node, and if this was a female mice, the breast tissue would be about there, right? See, I can learn. So this technique was developed by Hansen Jeong, who was a postdoc in my group. He's now on the faculty at Samsung Medical Center. And so he created this model, and it's been picked up by Dennis and Ethel Pereira, who are postdocs in my group. So this then allowed us to longitudinally follow the growth of a lymph node metastasis. And so we can see isolated single cells, and we can see them start forming these focal aggregates, and eventually lesions that start replacing the lymph node tissue. And Hansen was the first one to really notice that these isolated single cells didn't seem to lead to that lesion. It wasn't really looking like a clonal process. So what he did is he took cancer cells, same cancer cell line, this is a squamous cell line, made them green, made them red and green so they look yellow, and then took those three colors and basically mixed them back into a primary tumor, grew the primary tumor, and then said, what do my lymph node metastasis was? Basically as a test to see if they could form more clonal lesions. These lymph nodes, all these lesions that started to form, all had all the colors. And when you had these large lesions, they always had all three colors. So it didn't seem to be clonal, and that was different from what you would see if you looked at a lung metastasis. So here's just a two-color tumor looking at spontaneous lung metastasis where 80% of the nodules formed just with one color. 20% had multiple colors. And I think this really just speaks to the differences in the formation of how a metastasis in the lymph node forms versus that of a hematogenous metastasis. When you get a lymph node metastasis, you've got an afferent lymphatic vessel dumping stuff into the subcapsular sinus, including your cancer cells. And so it's a very localized position, but as those cells start to try and form a lesion, there's a constant reinforcement from the primary tumor bringing more and more cancer cells. Where when you think of a hematogenous metastasis, you have these circulating tumor cells, they hit the pulmonary artery, and now they're going to start going through all the bifurcation. So it's be kind of a rare event. You're going to get two cancer cells landing in the same spot. And so that's why you see more clonal metastasis in the lung. Now, we actually think these mixed color nodules were probably from clumps of cancer cells that were migrating together, and that's been shown with a lot of circulating tumor cell work. So we could see these differences in lymph node metastasis. What's going on with the vasculature? So I'm going to sort of illustrate some of our longitudinal imaging in the lymph node, and it's a very busy slide, so I apologize, but I think it's illustrative for what we see, so I will walk you through our experiment. So again, we're growing a primary tumor. We're letting it spontaneously metastasize into the lymph node. We then remove the primary tumor, build our lymph node window, and that sort of all happened in the first 21 days. So at day 22, we start imaging, and as you move across the screen, you're moving forward in time. And as you move down the screen, you're looking deeper and deeper into the lymph nodes. This is taking thin optical sections with multiphoton microscopy. So at day 22, you can see a few isolated cancer cells sitting up in the subcapsular sinus of the lymph node with the normal quiescent tumor lymph node vasculature sitting below it. Day 25, day 28, this lesion starts getting larger. But again, the lymph node vasculature is so sitting down below, not really changing. Now, if we took these same cancer cells, grew them in our primary tumor, waited 6 days, what you'd see is the blood vessels from the surrounding tissue rush in to perfuse that tissue. You'd see that prototypical Folkman sprouting angiogenesis occurring. That's not what we're seeing here. Day 34, we're now seeing a thicker lesion that's growing, but again, we're not seeing blood vessels where the cancer cells are. It isn't until we have a huge lesion by about day 40 where we see the vasculature associating with the cancer cells. So we're not seeing that sprouting angiogenesis that we were predicting. We tried to be a little bit more quantitative about this. So what we did is we measured the depth of our tumor growth into the lymph node from the surface, and that's the black line. And then we measured the more superficial aspect of where we'd see lymph node vasculature, and that's the red line. And so you can actually see the lesion was literally growing on top of where the vasculature is, and then started to push the tissue down and basically invade where there was already a very rich pre-existing lymph node vascular supply. So this is with intravital microscopy. We can then look with more traditional methods. So this is immunofluorescence for CD31 to identify blood vessels, and the green is our 421 cancer cells. And so this is a control lymph node. So for control lymph nodes for us is from a completely tumor-naive animal, and then contralateral nodes, metastatic nodes. And when you start comparing vessel density across these, the metastatic nodes at a slightly lower vessel density. And if you just segment out where the tumor was and compare it to the rest of the node, the tumor area always had a lower vessel density. So we're not seeing sprouting angiogenesis when we just stain for blood vessel density. Do we see any proliferating endothelial cells? So using Ki-67, we found plenty proliferating cancer cells, but very few proliferating endothelial cells. And in fact, the metastatic lymph nodes had fewer than the other nodes, but all levels were very, very low. So we're not seeing proliferating endothelial cells. Do we see the induction of any angiogenic growth factors? So using array technologies, we looked for angiogenic growth factors. There's VEGF for reference, and really didn't see the upregulation of any angiogenic growth factors. The two molecules that came up were TIMP1 and thrombospondin 1, which are both thought to be anti-angiogenic molecules. And when we stained for thrombospondin 1, we basically found it sitting right outside the lymph node vasculature, both in our control, contralateral, and metastatic lymph nodes. So with longitudinal intravital microscopy, we're not seeing sprouting angiogenesis. We're not seeing increased vessel densities. We're not seeing proliferating endothelial cells. We're not seeing the upregulation of angiogenic growth factors. And the factors that do come up are anti-angiogenic molecules, one of which is sitting right outside the lymph node blood vessels. So we think we could predict what's going to happen if we try and treat this with an anti-angiogenic therapy, right? So, but since I'm mean, I made the postdoc do the experiment anyways. So what we did is we grew our primary tumors, let them spontaneously metastasize into the lymph node, removed the primary tumor, built our lymph node window, and then began treating with 2 drugs, sunitinib, which is another small molecule tyrosine kinase inhibitor, and DC-101, which is a monoclonal antibody against mouse VEGFR2. And basically, the drugs did nothing to that vessel density over time and didn't alter the natural sort of growth of these metastatic lesions. So we don't see angiogenesis. Not surprisingly, we don't see an effective anti-angiogenic therapy. So that was all done in mouse. What about human specimens? So we wanted to identify a source of untreated lymph node metastasis. And we also wanted to actually work in a cancer where anti-angiogenic therapy had been approved. And so Dan Watson, who was a resident in radiation oncology that was working in my group at the time, he's now an attending up in Minnesota, identified a group of colon cancer patients at the Mass General that were initially diagnosed of not having metastatic disease. So they got sent for a primary resection of their tumor, and they do a block resection. So they basically like cut out a chunk of colon, sew the colon back together. And so when they come out, we get these lymph nodes hanging off. And it wasn't until the pathologist looked at those lymph nodes that it was determined that that patient actually had lymph node metastasis. So that's how we were able to get untreated nodes. And so this is just an example of a lymph node metastasis. We were staining with CD31. And so when we started looking at the vessel density, comparing metastatic lymph nodes and lymph nodes with disease in them, the tumor-bearing nodes always had a lower vessel density. And again, if we just segmented out in a metastatic lymph node where the tumor was, the tumor area always had a lower vessel density than the surrounding lymph node tissue. So in untreated lymph nodes, we weren't seeing any induction of angiogenesis either. What about in lymph nodes that were treated with anti-angiogenic therapy? And so for this, I was able to collaborate with Rakesh Jain, who was at Mass General, and Chris Willett, who was at the MGH when the trial started, and he was actually moved to Duke for the rest of the trial. And they were running a trial in rectal cancer patients that received chemotherapy, radiation, and bevacizumab. Bevacizumab is the monoclonal antibody against VEGF-A. It's Avastin. And so these patients got chemotherapy, radiation, bevacizumab in the neoadjuvant setting. So this is all before surgery. So then when the patients went for their surgery, we were able to get the treated tissue. And many of those patients had lymph node metastasis. And then we had a control cohort that just saw the chemotherapy and radiation. And so again, comparing vessel densities of treated lymph nodes with bevacizumab to that in non-metastatic nodes, there's no vessel density. Metastatic nodes, no difference with bevacizumab. And again, note, metastatic lymph nodes had a lower vessel density than the non-metastatic lymph nodes, again, consistent with untreated nodes and what we saw in our animal models. And again, if you just look at the tumor tissue, bevacizumab had no effect. So in our clinical samples, we're also not seeing angiogenesis or an effective anti-angiogenic therapy. And for us, this was just basically highlighting that some tumors can grow without inducing sprouting angiogenesis. And that might actually be a reason why many of the anti-angiogenic therapies haven't been as successful as were originally hoped. In fact, I think there's only one phase 3 trial of anti-angiogenic therapy in the adjuvant setting that's actually shown a positive outcome. And that is a lot of trials where it hasn't worked. And so we think this might be one mechanism. And then shortly after we published this work, Andy Reynolds in the UK looked at a series of liver metastasis. And he highlighted different ways where you can get tumor growth without the induction of angiogenesis. And one of the forms of liver metastasis and growth that he highlighted, he called the replacement model. And what he saw was cancer cells basically going in and kicking out hepatocytes and using the pre-existing sinusoids in the liver that were there. And I really like that explanation because I think that's what we see with our lymph node metastasis. We really see that the cancers are growing down to where that very rich pre-existing vascular supply is, and they're utilizing it. So they don't need to induce sprouting angiogenesis because it's already there. So this paper, we eventually got published in JNCI in 2015. And JNCI was not the first place we sent this paper. we actually sent it to 4 other journals, and it got reviewed each time, sometimes multiple times. And the peer review feedback that we got, let's just say there was a diversity of opinions on this work. And some of them were supported, and they asked us to do like 1 million experiments, but there were reviewers that were fundamentally asking us why we were spending our time, wasting our time, studying lymph node metastasis and trying to treat lymph node metastasis, because in their view, it didn't affect disease progression. It was really just this nice prognostic indicator. And we received this feedback fairly consistently, so we really wanted to understand what the problem we were trying to solve by studying lymph node metastasis was. And so what did we know? We knew that lymph node metastasis were probably the strongest prognostic indicator in disease. A patient with lymph node metastasis does worse than an otherwise equal patient that doesn't have lymph node metastasis. And the question is, why is that true? And so one school of thought is that lymph node metastases are really just a sign of the aggressiveness of the primary tumor. If it can get to a lymph node, it can get anywhere in the body. And the reason we see it lymph nodes first is because that's where we look. That's where we sample. It's easier for a surgeon to go get a sentinel lymph node and then have a pathologist say whether there's cancer or not. You can't take out a whole lung and go through that same process. And so that's the correlation. It's just a sign of aggressiveness. Where others had the view that lymph node metastases really were the gateway and a mode of metastasis that's necessary to help spread the disease further. And so I sort of started this by joking a little bit about the peer review process, and I actually don't want to sound negative about the feedback that we got, because I think those reviewers that were asking us about why we were studying lymph node metastasis were actually addressing a really critical question. And I think they had they were thinking in the right way because they had the patient's interest in heart. Because if lymph node metastasis are a gateway for further metastasis, then we're compelled to treat them. But that treatment doesn't come without a cost. 3 million Americans are walking around with lymphedema because of cancer therapy, right? But, so really what we really need to be able to understand who needs to be treated and whether there is a danger to lymph node metastasis. And we weren't the only people thinking about this question. There was people starting clinical trials to address this, and I'm just going to highlight 3. And there was 2 in breast and 1 in melanoma. And essentially they all took early stage cancer patients that had positive sentinel lymph nodes. So the sentinel lymph node is the 1 or 2 nodes that's the first draining lymph nodes from a tumor. And so it gets identified, removed, and the pathologist will look to see whether it's positive or negative for disease. And so again, early stage cancer patients, positive sentinel lymph nodes, randomized to complete nodal dissections and no further surgery. The outcomes of those trials showed no difference in overall survival. So this then brings the question, why are lymph nodes such strong prognostic indicators? Is it that it's really just the cancer can get whatever it wants at this point, and we don't need to worry about the nodes? However, there's caveats to these trials, in that the patients that didn't get the surgery did get chemotherapy radiation. And so there's an alternative explanation for these trials, which is that chemotherapy and radiation is sufficient to treat lymph node metastasis. And that was borne out in a different series of trials. And I'll highlight the one on the bottom here first, the Amorose trial, which is, again, early stage cancer patients, in this case breast cancer patients, with a positive sentinel lymph node randomized to radiation or surgery. No difference in overall survival. Patients that got radiation had fewer incidences of lymphedema, so that's good. And then there was 2 other trials published in the New England Journal that basically added radiation to tumor-draining lymph node beds that at the time didn't have a diagnosis with metastasis. And in those trials, adding that radiation improved cancer-specific survival. So here's a case where treating lymph nodes is actually improving outcome. So where does this leave us? Well, for us, a little confused, but we thought we had some unique tools and opportunities to be able to try and address part of this question. And again, we knew we weren't the only people trying to do this. As we started this work, we found out Dancho Kariashki and Michael Sixt in Vienna were trying to address the same question using different techniques. So at the end of the day, our papers came out back to back in the same journal. So that was a nice confirmation of our works for each other. So to try and break this question down to something that we felt we can address, the question we wanted to ask is, if we had cancer cells in the lymph node, could they actually spread further in the body? Can cancer cells be a source of distant metastasis? And so this work was taken on by a very talented postdoc in my group, Ethel Padera. And the approach that she took was to use photo-switchable proteins. And the one she chose was Dendra2. And so Dendra2 is a protein that's natively expressed green. And then if you expose it to certain wavelengths of light, that protein turns from green to red. And so she is able to transfect cancer cells so that she can turn them from green to red. So she then grew primary tumors, which are going to be green, let them grow, spontaneously metastasize to the tumor-draining lymph node. She then surgically removes the primary tumor. And then she only would expose the lymph node to the photoconverting light. So now she had red cancer cells in the lymph node that could only have come from the lymph node, and then asked, where do I see these cancer cells? Can I see them circulating in the blood? Can I find them in a distant metastatic organ? And so first looking at the circulating blood, she basically took blood out of the animals, ran it through a flow cytometer. It was an image stream system, so it actually has a camera to take a picture of each event to verify that the positive events were actually cells. And in photoconverted animals, we have red color on the x-axis. In 2 out of the 3 models, she was able to identify red cancer cells circulating in the blood that must have come from the lymph node. And that was in a 4T1 breast carcinoma model and the B16 melanoma model. In a third model, our SSC7 squamous cell model, she didn't see the red circulating cancer cells. So not in every model, but we were able to see the exit of cancer cells from the lymph node into the circulation. Do those cells get anywhere interesting? Well, Ethel then took the lungs out of these animals and took many, many, many sections through them using confocal microscopy, and she was able to identify red cancer cells in the lung of these animals. Again, in the 2 models, the 4T1 and the B16. In that SSC7 model, again, we didn't see the circulating red cells, we didn't see them in the lung. So here's direct evidence that cancer cells from a spontaneous metastasis can leave the lymph node and get to other places. But is that the only source of lymph node or of circulating tumor cells? So Ethel then grew her primary tumor, let it grow and establish, photoconverted the primary tumor to create some red cells in that primary tumor, and then asked, do I see circulating red cells? And she did. So now we have 2 sources to get circulating tumor cells, from a lymph node metastasis and directly from the primary tumor. So of course, we want to ask, which one's more important? And that really highlights the limitation of the Dendra technique. So with Dendra, we're photoconverting the protein itself. So the cell is sitting there making green protein. We shine light on it. Some of those proteins turn red. And that protein will eventually degrade over time, or the cell will divide and dilute it out. All the while, your cell just keeps making more green protein. So if you look after 5-6 days, all your cells are green again. So we can't track those red cells long term. So Ethel took the approach of just permanently labeling the same cancer cells red and green. She implanted a primary tumor red on the side where she had previously prophylactically removed the tumor-draining lymph nodes. And then on the other side, she directly injected cancer cells into the lymph node. Let those tumors grow and establish, surgically remove them, let the mouse incubate lung metastasis, and then ask, what colors do I see in the lung? Do I see red from the primary tumor? Do I see green from the lymph node tumor? And she found both. So this is one mouse lung. And so in each case, she saw a contribution from both the primary tumor and the lymph node. It was heterogeneous across different animals, and some it was more from the primary tumor, others more from the lymph node. But in each case, there was a contribution to established lung metastasis from the lymph node tumor. So we see cancer cells leaving the lymph node, getting and colonizing distant metastatic sites. How do the cells actually leave the lymph node? Well, there's actually 2 different routes you can imagine these cells could take. So here's our lesion growing near the subcapsular sinus, moving toward the vasculature because it needs a metabolic supply. It could leave through the efferent lymphatics. And clinically, that's seen because you can actually find lymph node metastasis in patients down chains of lymph nodes. And Doncho Karyachki had previously shown the invasion of the medullary lymphatics by cancer cells, so that seems possible. But because Ethel was doing lots of intravital microscopy, she was noticing that these cancer cells seemed to be associating with the lymph node blood vasculature, that they seem to have a tropism for them. And so I'll show an example of some of the time-lapse intravital microscopy that she was doing in the lymph nodes. So these are green cancer cells, red blood vessels. Video drives me crazy because like 2/3 of the time it runs fine, and the other third it stops. But the main take-home points from this video is that most of the cancer cells aren't very motile. This isn't like the lymphocytes that are crawling around really fast, so they look more like a stromal cell. But in these boxes, we see more directed migration, and that directed migration is always toward blood vessels. I can make that more obvious up here, where we false-colored all the non-motile cells purple, and the one motile cell is that yellow one, and you can see it moving toward the blood vessel. And then here's another example of cancer cells basically crawling all over a blood vessel. So we can see this phenomenon with intravital microscopy. So we went back and started looking very carefully at our lymph node metastasis sections. And with this, we can stain the endothelial cells and see that the cancer cells are associating with the CD31 positive endothelial cells and getting caught up in the basement membrane. So how can we actually try and establish that there's a tropism of the cancer cells for the blood vessels? And so we thought, well, if the cancer cells were associating more with the blood vessels, they'd be closer than if the cells were basically ignoring the blood vessels and were just randomly distributed in the tissue. And so the approach we took was to make many, many sections of our lymph node metastasis, stain for cancer cells and blood vessels, and then segment out where all the blood vessels were. And that basically allowed us to make a map in each individual section of where all the blood vessels were. We can then take our cancer cells and measure the distance to the closest blood vessel. And so each cancer cell, we had a distance. We could plot that as a histogram, and that's that red distribution there. So we needed to compare that to something. So again, if our hypothesis is that there's a tropism, we're going to see cancer cells more associated with blood vessels than if at random. So what we did then is we took those maps of each individual lymph node tissue with our blood vessels and randomly distributed cancer cells on them, mathematically. And then so we oversampled, and then we're able to take our mathematical fiducials, measure the distances, and create another distribution, which is this white distribution. So you can see the cancer cells are closer to the blood vessels than if they were randomly distributed. And then we can show that statistically below. So we see this tropism. Do we actually ever see cancer cells inside blood vessels? So again, looking at our tissues in the mouse with immunofluorescence, these are now thick sections. We're able to identify cancer cells inside lymph node blood vessels. Surprisingly, this actually was a more common phenomenon the smaller the metastatic lesion was. When we saw larger lesions, we actually saw this less than when we saw smaller lesions with individual cells kind of crawling off. And commonly, we find these cells inside the high endothelial venules in the lymph node. So the high endothelial venules in the lymph node are commonly where naive lymphocytes leave the blood vasculature to get into the node. And we can potentially talk about why that might be. So that's mouse. What about in humans? So we looked through a series of 19 head and neck squamous cell carcinomas with lymph node metastasis. We only had about 1 or 2 sections per case, so we were very undersampled. But in 6 out of the 19 cases, we were able to identify cancer cells sitting inside lymph node blood vessels or cancer cells about to invade. So I'm pretty much out of time, so I just sort of want to quickly wrap up this last part of the talk and really start to hopefully convince you that as these metastatic lesions grow in the lymph node, they aren't inducing sprouting angiogenesis. They're really starting to grow down and utilize that pre-existing lymph node blood vasculature to meet their metabolic demands. And in that process, they form this tropism or attraction to the blood vessels that allows them to then invade. And from there, they circulate into the blood, and they can find their way to a distant metastatic site. So with that, I think I'll just thank the people that did the work. First, I want to thank Dennis Jones, who's here. He's a current postdoc in my group, and unfortunately for me, fortunately for him, I can only say that for like another 2 weeks because he'll be starting his faculty position as an assistant professor at Boston University at the beginning of October. And so he did the work. The quick little story I told you about the bacterial infections, shutting down lymphatic contraction, as well as a lot of the work on the lack of angiogenesis in the lymph node. I also want to thank my talented postdoc, Ethel Padera. She really took on this project looking at the spread of metastasis from the lymph node, and now she's continuing that work because, in my view, that's sort of an unfinished story. We've basically shown that it is possible for disease to spread from the lymph node on, but there is nothing actionable to do yet because we don't understand the biology. And so what Ethel who is now starting to interview for faculty positions and look for faculty jobs, wants to build her lab, is trying to understand that biology of how that cancer cell can leave and how the lymph node microenvironment influences things that are happening with the cancer cells as well. Also thank Eka Bote and Elko Meyer and Ki-Hoon Jiang, who actually just started his faculty position as an assistant professor back in Seoul at Seoul National University. So you can see I'm actually losing a lot of people, so if anyone's looking for a postdoc, I could use some help. I'd like to thank Rakesh Jain, Lance Munn, Ben Bakic. I should have included Ryan Lanning on here now as well, Mike Carroll, Michael Otto, and the NIH for the funding. And I'm happy to take your questions. So. Yeah, so the question is, with the known pathways for the bacterial infection affecting lymphatic muscle, is there a therapeutic target? So it's actually something we struggled with because we could identify the toxins and try and target them and remove them from the tissue. We could try and block the AGR. As I thought more about this, I've come to believe that it's going to be too late. Like once you know we see the destruction to lymphatic muscle cells happening pretty quickly, like within a day or so. So my feeling is it's too late. To me, I think the most interesting question is, why don't the lymphatic muscle cells regenerate? So if we look very early in the infection, we see the loss of vascular smooth muscle cell and blood endothelial cells, so we see lots of hemorrhage, and we see the loss of lymphatic endothelial cells. If we look at 30 days, the vascular smooth muscle cell is perfect again. There's no leakiness out of the blood vessels. The lymphatics have good barrier function, but they don't contract anymore. And this is long. It's 260 days. We see like very slowly increasing lymphatic muscle cell coverage over time, but we have no idea why they don't regenerate. So for me, in terms of therapy, just because I don't think we'd ever be able to intervene early enough to prevent it, that I'd love to be able to figure out how we can get these lymphatic muscle cells to regenerate, to keep that pumping going. But I know there are people, and I think there's someone in the immunology department here that's actually an expert in the AGR and has been thinking about targeting it, because the AGR does a lot more than just shut down lymphatic pumping. There's a lot of other reasons to target. So if those molecules come along, I'd surely give it a try for sure to see how it affects lymphatic function. No, that is the question, right? That is the, like, if you ask physicians that have to treat these patients, that is their, like, hard decision. That is their pain point. Right, and if you're, it's less, right? So I think that is becoming the sort of preferred course of action with a positive sentinel lymph node. I think it depends a lot on individual patient characteristics and how worried you are about distant spread. The other issue now is you'll get a whole bunch of immunologists coming in and saying, don't irradiate the heck out of the tumor-draining lymph nodes because those are the ones where you might have memory and you might have other, right? So it's a very interesting, right? And so, it's a very interesting time to be thinking about lymph node metastasis. And I'm not going to stand up here and say, I know, I have all the answers, because I don't. But I think it's a good area to start thinking about if you're thinking of new research projects, because there's so much work to be done. Yeah. Yes. Yeah. I pretty much will not, because I study lymph nodes, I will not look at immune deficient animals because the lymph nodes are bizarre. Yeah. So that's why we have one other breast model that somewhat metastasizes, but my postdocs, they basically, it has a very high PPI, which is the post-hoc pain index, the other model, because you only get, you inject like 5 or 20 animals to get 3 lymph node metastasis, and so they don't like that. So that's fine. Yeah. 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 So there are, I think, 6 total over the past 5 or 6 years that have tried to address this question of sort of the phylogenetic tree of where metastasis arise. So there's a paper in PNAS who's actually from Rakesh Jain, and they showed 65% of the time the closest phylogenetic neighbor of a distant metastasis was the primary tumor, which means 35% of the time the closest phylogenetic neighbor was the lymph node, right? I'm not claiming that this happens in every single patient, right? In 2 of 3 models, we don't see it. In 6 out of 19, we don't see it. Do I believe that you can get direct dissemination from a primary tumor to a distant site? Yes. So I don't think the lymph node is the only route of metastasis. I think you can get direct dissemination from a primary tumor. I think you can get direct dissemination to a lymph node and it stops. I think you can get dissemination to a lymph node and it goes to a whole bunch of other lymph nodes and stops. I think you can go through a whole bunch of other lymph nodes and maybe get to the circulation. And I think it can invade lymph node blood vessels and go systemically. And like I said, I think, this was proof that lymph node metastasis can spread, but I think it's a sort of an unsatisfying paper in many ways because we don't know the answers to all these other questions and how you can identify in an individual patient what their biology is to be able to predict whether they're at risk of spreading from the lymph nodes. The other comment on some of those sequencing papers is that the way they do the analysis doesn't account for multiclonality, particularly in the lymph node lesions. And so when we see multiclonal lymph node lesions, and many of the sequencing papers show that as well, but when you start accounting for the multiclonality and the selection processes in the lymph node, it's a probabilistic game because those same sequences in distant metastatic sites probably are also in the lymph node because the lymph node is really representing what's in the primary site. So there's sort of, at some level, it's a statistics game of saying that it's more probable, but it doesn't mean it's 100% that it's more likely coming from the primary tumor. But again, I do believe that it can be, in a portion of those patients, I do believe that it's likely distant metastasis came directly from the primary tumor. So, does that address your question? Okay. Okay. So we haven't looked at macrophages. The cell type that has drawn our interest, and this is like a project that Ethel's trying to finish up before she leaves, is looking at a stromal cell in the lymph node called the fibroblastic reticular cell. So the FRCs basically line a conduit system in the lymph node. So the conduits basically are little collagen wicks that help bring fluid from the subcapsular sinus, hopefully with some free antigen down to where naive lymphocytes are. And those are coated by these FRCs, which also produce tons of chemokines that then help attract dendritic cells. So a dendritic cell path down to naive lymphocytes is usually following these FRC paths down. And so what Ethel's trying to ask is, are the cancer cells basically using that FRC network as basically a scaffold? So if you look at Condios' work, he also shows that you need collagen scaffolds to crawl on. And so we're sort of more thinking that that's it, because there's basically a chemokine path from periphery down to naive lymphocytes, which is where the HEVs are. And that's, sort of one of the hypotheses that we're using of how they're able to escape. Thank you.